Okay, now this is a very interesting case. Is a 5-year-old boy with fatigue, decreased hemoglobin, and increased reticulocyte, and red blood cell fragment and direct antiglobulin negative. So, what do you think is the diagnosis? This is most likely first thing we do G6PD dehydrogenase assay, because first of all it's when you have increased reticulocyte, decreased hemoglobin, that's hematocrit, that's hemolysis. Sorry, period. We don't do cold agglutinin. This happened after a viral infection. They have hemolysis. If that was the case, then direct antiglobulin Combs test will be positive. Here is negative, so that's not the case. Okay, bone marrow biopsy, it's not. Why? Because this will present with multiple cell lineage will be decreased. No, here any numerical value that's normal, I did not give it. So I only give you the abnormal ones, which is this one. That means the leukocyte is fine. So we can't do normal. We can't expect abnormalities in the bone marrow if the leukocyte is fine. Okay, so this is how you think it out. Thalassemia. So thalassemia and sickle cell anemia, this one, we do that hemoglobin electrophoresis for thalassemia and hemoglobin and sickle cell. So anemia and thalassemia present microcytic. That's the difference. While this patient is normocytic. And the other thing, pain crisis starting in infancy and sickle red blood cells on peripheral blood dyspnea, you see, on RBC. See here, red cell fragment. You don't see sickle red blood cells. So that's the difference. Osmotic fragility test is for hereditary spherocytosis, okay, which are present with a spherocyte on peripheral smear and splenomegaly on examination, which neither present in this patient. So that's about it for this case. That's the summary period. Let's go next. Okay, so the story of this patient is that this is a 34 young man who wants opioid. So before you give him opioid, you gotta take history, confirmation of the patient medical and prescription history before proceeding further. Like, ask him to sign a pain contract and refill opioid prescription. No, this is maybe helpful in decision making, but it's not, doesn't help like to prescribe opioid. It's not as important as this one. I was getting information. So here I want you to know the risk factors for opioid abuse. It's a personal or family substance abuse, if any of the family have that. If there is a psychiatric disorder, that's a substance abuse. The feature concerning for drug abuse is that drug-seeking behavior include requesting high doses or specific medication by name, running out of the medication, reporting lost or stolen medication, pain out of proportion to the physical examination. So that's what do you expect? Like, those are the findings in opioid abuse. Okay, so that's about it. This question is not important of a comparison. Okay, so we'll go to the next one. Oh, so this is a really good question. Now, when you have a 33-year-old female who present with abdominal pain that began couple of weeks with mild episodic, but now it's constant and relieved by ibuprofen, she have constant nausea, multiple episodes of emesis, tender right adnexal mass, urine pregnancy is negative. So what is the best next step for this patient? So this is most likely ovarian torsion. This is typical presentation. Small, non-tender, tender right adnexal mass. Okay, so that's why we do pelvic ultrasound with Doppler. That's the best thing. Chlamydia and gonorrhea, so there are risk factors which guide our conclusion, which is very important. So the risk factor for chlamydia, gonorrhea, multiple sexual partners, 15 to 25-year-old girl, they tend to have more sexual partners. So that's we order chlamydia and gonorrhea. But this girl is not important. CT drainage of the mass, no. So this is not managed by CT drainage. It's not an abscess. This is an abscess. Abscess will be fever, swinging fever, and pain is so severe. It's different. IV antibiotic for PID, which present with fever and stuff like that. Pain control is also important for someone with the ovarian torsion, but we gotta diagnose first too. And now outpatient follow-up. We don't do outpatient. This is something serious. We gotta do surgical detorsion. That's a definitive treatment. And salpingo-oophorectomy is reserved for obvious adnexal necrosis or when you suspect ovarian malignancy. And if you don't treat torsion, this can cause chronic pelvic pain and infertility. So now someone asking, what are the risk factors for torsion? This is the risk factors: pregnancy, ovulation induction during infertility, treatment, and ovarian masses more than 5 cm. Those are risk factors for ovarian torsion. Period. So we'll go to the next one. Okay, so when you are a 62-year-old man returned from evaluation of a hypertension and you presented with the heart, there's maximal impulse palpated lateral to the midclavicular line, heart sounds are normal. So there are intermittent claudication, erectile dysfunction, diabetes, hyperlipidemia, coronary artery disease. So this tells you there's a diffuse atherosclerosis. So when you have resistant hypertension, okay, plus diffuse atherosclerosis, that raises significant risk for renal artery stenosis. So what do you do right now for renal artery stenosis? The first thing you do, duplex ultrasonography. Why not serum aldosterone? Why not the other ones? That's why. So there's worsening renal function already. So, and he's already on lisinopril. So we don't want to give spironolactone. This is worsen his renal function. Losartan is the same, can worsen his renal function. Angiography with renal arteries, like contrast, any contrast to the kidney, this is damaging. So we don't want to do that here. Okay. So serum aldosterone level, there is no need for that because we're diffuse atherosclerosis. This is most likely it's a renal artery stenosis. So if we measure serum aldosterone, it's not going to give us anything. Maybe if there is not atherosclerosis, then and we're suspecting Cone syndrome, like primary hyperaldosteronism, they will have high plasma aldosterone to renin ratio. And present with resistant hypertension with unexplained hypokalemia, that's how you diagnose that. Okay, so that's the difference, period. Okay, so if you have a patient who keeps on calling you for like different simple reasons, so the way you treat them, you just tell them, I appreciate you wanting to keep me informed, but let's review the situations warrant an urgent call. So that's an ethic question. Yeah, that's about it. Okay, let's go to the next one. So now this is a really good case. So the guy, 45-year-old, he's having back pain, osteomyelitis, dactylitis. So he's having TB, pot disease in the vertebra. So now there's no problem, why not with him? The problem not just with him, with the healthcare personnel. So unless they are covered with airborne isolation or N95 mask, then he's at these guys are at risk. So what should you do like right now? So the best thing to do is that repeat tuberculin test in 6 to 8 weeks, in 8 to 10 weeks, sorry. Okay. That's the best thing to do. So this option saying no further measures are necessary, actually no. Screening for TB is important up to 8 weeks following exposure, and repeat testing is required to evaluate transmission so that appropriate treatment can be administered, because TB is important to detect it before it develops to active, detect it latent. Chest radiograph and sputum for acid fast vasculitis. This is if the screening was positive, then we can go to the next step for these ones. Okay, repeat TB, this one the right answer. Start treatment with isoniazid and pyridoxine. This is after the positive TB. Stay home and monitor for symptoms. Nah, come on, why would you let them stay at home? Okay, no, never do that. So just repeat TB in 8 to 10 weeks, period. Let's go next.